Examination of the heart includes techniques of inspection, palpation, percussion, and auscultation. Emphasis is placed on the functions of the heart. However, the entire body must be carefully examined for the manifestations of the heart action. During the total physical examination, you may also assess the thorax, lungs, and breasts at this time. The heart is assessed primarily through the anterior thorax. Basic anatomic landmarks of the thorax are helpful in identifying the underlying structures. Anterior landmarks include the left and right clavicles attached to the manubrium of the sternum. The suprasternal notch is located at the top of the manubrium. Located a few centimeters below the notch is a slight ridge protruding forward where the manubrium connects with the body of the sternum. This ridge is called the angle of Louis. Attached laterally at this point are the right and left second ribs. This space below the second rib is the second intercostal space, followed by the third rib. From here you can number the ribs and intercostal spaces as you palpate at the sternal border down to the seventh rib. The costal margins are formed by the 8th, 9th, and 10th ribs. The area between the costal margins is called the costal angle. The 11th and 12th ribs are posterior. The intercostal spaces are used as horizontal reference points. Imaginary lines are used as vertical reference points. The imaginary vertical lines are parallel to each other. The midsternal line extends from the suprasternal notch through the xiphoid process. The midclavicular lines extend downward from the middle of each clavicle. The anterior axillary lines follow the lateral thoracic walls on each side. You document points of reference as so many centimeters medial or lateral to these imaginary lines within a specific intercostal space. The heart is located within the area called the mediastinum. The base, or upper border, is tilted towards the right side of the body just below the second rib. The apex, or lower border, lies about 8 centimeters or 3 inches to the left of the sternum at the level of the diaphragm. Thus, 2/3 of the mass are to the left side of the midsternal line and 1/3 to the right side of the midsternal line. As seen here, the right border of the heart extends from the second intercostal space to the fourth intercostal space at the right sternal border. It is mainly formed by the right atrium. The right ventricle is located below the right atrium, extending from behind the sternum towards the left. The left border of the heart is mainly the left ventricle, which extends from the fifth intercostal space to the third intercostal space, approximately 8 centimeters to the left of the midsternal line. The left border continues a short distance as the left atrium to the second intercostal space. Obtain a complete health database prior to the physical examination. Brief examples of the kinds of information you would want to know relating to the heart assessment are presented here. There may not be any complaints if this is a routine examination. However, if the client has identified a potential or current cardiac problem, you would direct questions to obtain further information. Complaints of pain, dyspnea, edema, and so forth should be characterized in detail as to location, onset and duration, circumstances when occurring, severity, aggravating factors, relief measures, and any other symptoms associated with the complaint. Identify any contributing factors, general health status, any medical diagnosis of heart disease, hypertension, diabetes, any physical trauma such as accidents or surgery, or any emotional trauma. Establish your client's lifestyle and potential for stress, occupational responsibilities, environmental, noise, smog, hobbies, and relaxation activities, play, exercise, nutritional habits, fast foods, eating out, canned food, etc. use of alcohol and or drugs, use of tobacco, frequency, when started, use of coffee, tea, colas. Identify hereditary factors, heart disease, hypertension, diabetes. Provide a comfortable, warm, and quiet environment. The client may use a cover gown prior to the actual examination, but then the entire chest must be exposed. Relieve anxieties by explaining that you will be applying pressure to the chest, tapping on chest walls, and listening to heart sounds. Continue to explain throughout the examination. Your initial inspection of the anterior chest is performed as the client is being positioned on the examining table. Observe for normal posture and chest configuration. Abnormal inward depression or outward projection of the sternum may alter the position of the heart. Inspection and palpation techniques of the precordium are utilized together with your client in a supine position, either at a flat or a 45-degree angle. You sit or stand at the right side of your client. Tangential light is helpful in observing chest movements. In a systematic manner, inspect and palpate the precordium over specific areas. The sternoclavicular area includes the upper part of the sternum and manubrium. The aortic area is located in the right second intercostal space at the sternal border. The pulmonic area is located in the left second intercostal space at the sternal border. Erb's point is below the pulmonic area in the left third intercostal space. The right ventricular or tricuspid area is located at the sternum and the left sternal border in the fifth intercostal space. The left ventricular or mitral area is located in the left fifth intercostal space, slightly medial to the midclavicular line. For evaluation of the epigastric area, refer to the program Health Assessment of the Abdomen. Inspect for chest movement and then palpate to confirm an observation or to detect invisible cardiac movement. Cardiac movement is more visible at the termination of expiration when the lungs are deflated. When visualizing or palpating cardiac movement, confirm the time the movement occurs in relation to the cardiac cycle by simultaneous palpation of the carotid artery. Ask your client to flex his neck and rotate his head towards the side you are palpating. Place your first 3 fingers, palmar side down, between the trachea and the sternocleidomastoid muscle. Palpate gently for pulsations. Avoid vigorous palpation. Stimulation of the carotid sinus reflex can cause bradycardia. The carotid pulse is felt during the systolic cycle as blood is ejected into the circulatory system from the left ventricle. Palpate the cardiac areas with the palmar surface of your fingers for pulsations. Then palpate over the entire precordium with the palm of your hand for abnormal thrills, friction rubs, heaves, or lifts. Sternoclavicular area, normal slight pulsations may be present. Bounding pulsations are suggestive of an aortic aneurysm. Aortic area, normally this area is quiet. Pulsations palpated in this area are also suggestive of an aortic aneurysm. Systolic thrills may also be felt in this area. A thrill is like the sensation felt when you place your hand over the larynx as the person is speaking. These vibrations are best felt by the palm of your hand. Thrills result from blood flowing through a restricted area, for example, an aortic stenosis. Move your hand over the pulmonic area. Normally this area is quiet. You may again feel pulsations when the pulmonary artery flow is increased due to mitral stenosis, pulmonary hypertension, or an atrial septal defect. Detection of a systolic thrill might be due to pulmonic valve stenosis. Erb's point is normally absent of pulsations. Pulsations are seen and or palpated in this area during systole in the presence of an acute myocardial infarction or during an anginal attack. In the right ventricular or tricuspid area, abnormal gradual lifts or heaves may be observed and palpated. These heaves are usually caused by increased pressure or hypertrophy of the right ventricle. Pulsations may be present at the sternal border when there is increased cardiac output. This would be normal during pregnancy. A systolic thrill may also be felt in this area, resulting from a ventricular septal defect which allows mixing of blood from the two ventricles. A pericardial friction rub may be detected along the lower left sternal border. A pericardial friction rub is a grating sensation felt during both the systolic and the diastolic cycles. Pericardial friction rubs are caused by pericarditis, an inflammation of the sac enclosing the heart. If the sensation corresponds with respiratory movement, it is probably a pleural friction rub. In the left ventricular or mitral area, you inspect for the normal apical pulse. During the ventricular contraction, the apex rotates forward towards the chest wall, producing an impulse, sometimes identified as the point of maximum impulse, or PMI. If you have difficulty visualizing or palpating the pulsation, ask your client to sit up and lean forward as you assess. This pulse is not always observed and/or palpated. If you are able to palpate the apical pulse, it will feel like a faint, short tap on the chest wall, approximately 2 centimeters or 1/2 inch in diameter. Normally, the pulse occurs during the first third of the systolic cardiac cycle. Its size and location is an indicator of cardiac size. The apical impulse is normally located in the left fifth intercostal space, at or medial to the midclavicular line. The pulse may be displaced lateral to the midclavicular line during pregnancy. In left-sided heart failure with left ventricular hypertrophy, the pulse may be located 4 centimeters lateral to the midclavicular line in the left sixth intercostal space. In right-sided heart failure, the pulse is displaced toward the right sternal border. Percussion technique in assessment of the heart is briefly presented. The technique is being used less frequently since the information obtained is not always reliable. The actual size of the heart is more accurately determined by chest X-rays, and the position of the heart is determined by inspection and palpation. With your client in a sitting position, start light percussion at the anterior axillary line within the fifth intercostal space. Resonance is the sound heard over normal lung tissue. Dullness is the sound heard over the heart. Normally, cardiac dullness is not detected to the right of the sternum because of lung tissue overlying the heart. Percuss towards the midclavicular line, listening for the change of sound from lung resonance to heart dullness. When the change is heard, note the location. Repeat within the fourth and then the third intercostal spaces. Estimate in centimeters the 3 locations where the changes of sound occur in relation to the midclavicular line. Normally, the cardiac border is located at or medial to the left midclavicular line. The final phase of the heart examination is auscultation. You assess heart sounds with your client in the sitting and the supine positions, using first the diaphragm and then the bell of the stethoscope. The diaphragm picks up the high-frequency sounds when pressed tightly against the skin. The bell picks up the low-frequency sounds when applied lightly to the skin. Exerting pressure on the bell will cause it to act like a diaphragm. Events in the cardiac cycle produce the heart sounds. The human heart is a double pump divided by a septum. Each side contains a small antechamber known as the atrium or auricle, and a lower, larger chamber called the ventricle. At the beginning of the diastolic phase of the cardiac cycle, as the ventricles relax, the right atrium is receiving venous blood from the systemic circulation by way of the inferior and superior vena cava, and the left atrium is receiving oxygenated blood from the lungs by way of the pulmonary veins. The increased pressure within the atria opens the atrioventricular valves, the tricuspid valve on the right, and the mitral valve on the left. As the blood flows through the ventricles, the rising ventricular pressure slows the flow from the atria. The atria contract to force in more blood for filling. As the atria relax, the atrioventricular valves close. The first sound, S1, is believed to be produced by the closure of the mitral and tricuspid valves. The systolic phase of the cardiac cycle starts with contraction of the filled ventricles. Increased pressure within the closed chambers forces open the semilunar valves, the pulmonic valve on the right, and the aortic valve on the left. Ventricular contractions eject the blood into the pulmonary artery on the right and the aorta on the left. Events on the left side occur at higher pressures than on the right side. As the ventricles relax, the semilunar valves close. The second sound, S2, is believed to be produced by the closure of the aortic and pulmonary valves. Rhythm of the cardiac muscle is maintained by an electrical conducting system consisting of two large nodes that transmit impulses. The electrical discharge originates at the sinoatrial node located in the posterior wall of the right atrium near the superior vena cava inlet. The sinoatrial node is the primary cardiac pacemaker, stimulating 60 to 100 impulses per minute. The impulses spread through the atrial muscles to the atrioventricular node located in the lower posterior wall of the right atrium. The atrioventricular node delays the impulse to allow atrial contractions to complete. Thus, the diastolic phase is longer than the systolic phase. From the atrioventricular node, the secondary pacemaker, the impulse passes by way of the bundle of His and its branches to the ventricles where ventricular contractions are stimulated. Valve sounds are reflected to specific areas where they are heard best. These areas correspond to the areas in which you palpated. A systematic assessment is done by inching the stethoscope from one area to the next. You may start at the apex or the base, eventually encompassing the entire precordium. Since many other sounds may be present at the apex, you may find it desirable to start at the base. The second sound is louder than the first sound when listening at the base, which is closest to the aortic and pulmonic valves. S2 is loudest at the aortic area. Sounds of the closure of the aortic valve are best heard over the aortic area. Sounds of the closure of the pulmonic valve are best heard over the pulmonic area. Reflected heart sounds are also heard at Erb's point. Sounds of the closure of the tricuspid valve are best heard in the right ventricular or tricuspid area. Sounds of the closure of the mitral valve are best heard in the left ventricular or mitral area. S1 is loudest at the mitral area. The first sound is louder than the second sound when listening at the apex, which is closest to the tricuspid and mitral valves. Explain to your client that you are going to be listening to heart sounds, and you will ask him to change position during the examination. The environment should be as quiet as possible. The room, examiner's hands, and stethoscope should be warm. The client's shivering will transmit false sounds. Listen first using the diaphragm, which is best for picking up the high-frequency first and second heart sounds. Start at the aortic area. Move your stethoscope by inches in a sliding fashion over the cardiac auscultatory areas. Heart sound S1 is heard at the beginning of the systole following the closure of the arterioventricular valves. S1 is a low-pitched sound. It sounds like lub. Heart sound 2, S2, is heard at the beginning of the diastole following the closure of the semilunar valves. S2 is a higher pitched sound. It sounds like dub. Listen carefully to establish the heart rate. S1 and S2 equal 1 beat. S2 will sound louder than S1 in this area. Listen to the interval between S1 and S2, systole, then listen to the interval between S2 and S1, diastole. The diastolic phase will be longer. Palpate the carotid pulse if you have difficulty distinguishing between systole and diastole. You can feel the pulse during systole. At Erb's point, the sounds are of equal intensity. As you move down to the apex over the right ventricular and then left ventricular areas, S1 sounds become louder than S2 sounds. If you have difficulty hearing S1 and S2 at the apex, ask your client to lean forward while you listen again. Usually a single sound is heard for S1 and S2. Events of the cardiac cycle occur on the right side slightly later than on the left side, which sometimes produces a second component of either S1 or S2. This is called splitting. Split S1 is usually heard over the tricuspid area. S1 reflects closure of the mitral valve, and the second component reflects closure of the tricuspid valve. This can be a normal sound. When the splitting is more pronounced, it is suggestive of pulmonary hypertension. Split S2 is more common and usually heard over the pulmonic area when the pulmonic valve closes slightly later than the aortic valve. This occurs as a normal physiologic splitting of S2 with respirations. The second component increases with inspiration because of the changes in intrathoracic pressure. When the splitting of S2 is still heard during expiration, it is suggestive of right ventricular heart failure or right bundle branch block. The bell of the stethoscope works best for picking up low-frequency third and fourth heart sounds. From the apex, with the bell placed lightly over the auscultatory areas, inch back up to the base. Sometimes you will hear additional heart sounds. The third sound, S3, is caused by vibrations of the rapid filling of the ventricles. The first two sounds are S1 and S2. The rapid sound following S2 is S3. It sounds like Kentucky. S3 is heard best at the mitral area. This is a normal sound in children and young adults, but is abnormal when heard in the client over the age of 40. An abnormal S3 is suggestive of left ventricular failure. When the extra sound occurs at the end of the diastolic filling, just prior to S1 sound, it is called the fourth sound, S4. It sounds like Tennessee. The first sound is S4, followed by S1 and S2. S4 is heard best at the mitral area. This sound may be confused with a split S1. Remember, a split S1 is heard over the tricuspid area using the diaphragm. S4 can be normal in a thin individual. Usually, S4 is an abnormal sound suggestive of hypertensive heart disease. Ask your client to assume a supine position. Systematically repeat auscultation with the diaphragm from the base to the apex, and then with the bell from the apex to the base. Ask your client to assume a left lateral position with his left arm raised above his head when listening at the apex. This brings the apex closer to the chest wall to enhance auscultation. Evaluate the heart sounds one at a time. For first, heart rate, S1 and S2 equal 1 beat. Then systole, the time interval between S1 and S2. Diastole, the time interval between S2 and S1. Intensity, where S1 is loudest at the apex and S2 is loudest at the base. Note and describe any extra sounds you may hear as to duration, intensity, location, and time during the cardiac cycle. If you wish to perform a complete auscultatory examination of the heart, you would have to refer to additional material to learn the abnormal sounds. A brief presentation of some of these sounds follows. Diastolic opening snaps are usually produced by stenosis of the mitral valve and sometimes the tricuspid valve. Systolic ejection sounds are produced by stenosis of the pulmonic and/or aortic valves. Systolic clicks are sounds produced by the ballooning of an enlarged mitral valve into the atrium with ventricular contractions. Pericardial friction rubs are scraping sounds caused by pericarditis. If the sound corresponds with respiratory movement, it is probably a pleural friction rub. Cardiac murmurs are sounds of turbulent flow of blood produced by an increased blood flow rate, blood flow through a stenosed valve, or regurgitant blood flow through an incompetent valve. A loud murmur may have been palpated as a thrill. Systolic murmurs occur during ventricular contraction. These may be due to incompetent arterial ventricular valves, stenosis of the semilunar valves, a ventricular septal defect, or alterations of aorta or pulmonary arteries. Diastolic murmurs occur during filling of the ventricles. These murmurs may be due to incompetent semilunar valves or stenosis of the arterioventricular valves. Innocent normal systolic murmurs are heard during childhood and in young adults with a normal increased cardiac output. Functional systolic murmurs result from increased cardiac output due to exercise, emotion, pregnancy, fever, etc. Accurate assessment of a murmur includes 8 factors. Concentrate on S1 and S2 sounds, then evaluate the timing of the murmur in relation to the cardiac cycle. Identify where it is heard by so many centimeters in relation to an intercostal space and an imaginary line. Note the direction in which the murmur is transmitted. Listen to the pattern levels of increasing and decreasing intensity. Grade from a faint sound, grade 1, through grade 6, the loudest possible sound usually heard with the stethoscope off the chest wall. Note the pitch, as high, medium, or low. Identify the quality as blowing, musical, or rumbling. Observe for the murmur intensity in relation to respirations. Does the sound increase or decrease with inspiration or expiration? Identify the murmur intensity in relation to positional changes. For example, aortic murmurs are heard best with your client sitting or leaning forward. Mitral murmurs are heard best with your client lying on the left side. Immediately after the examination, document your findings. Inspection, normal posture and chest configuration, no visible cardiac movement. Palpation, apical impulse with regular rhythm in 5th intercostal space, medial to the midclavicular line. Approximately 2 centimeters in diameter, no thrills, heaves, or rib retraction. Percussion, left border cardiac dullness at midclavicular line in 5th intercostal space. Auscultation, rate 80 beats per minute regular. S1 is greater than S2 at the apex. S2 is greater than S1 at the base. S2 split on inspiration at pulmonic area. No murmurs, clicks, snaps, or rubs. No S3 or S4 heard.